Hello, everyone, and thank you again for joining us for a Women's Heart Health Initiative sponsored by the Cardiovascular Research Foundation. We're here today to talk about a topic that we often haven't addressed enough. We talk about heart disease risk factors, including diabetes, heart failure, things like that, but we haven't really discussed cholesterol and what that means. And it's a concern for so many Americans, and something that typically is asymptomatic and often undiagnosed in the general population. So I am here with Dr. Sam Kim from Cornell University and Dr. Wahida Karmally, who's also from Columbia University. And we're here to talk about cholesterol and heart health. And I'm going to start with just an introductory set of slides to talk about how is it that our cholesterol profile actually affects cardiovascular disease. So what exactly is cholesterol? It's actually, we call it lipids as well, but it's actually a waxy molecule that's made by your body. So the liver actually makes all of the cholesterol that a person needs. And you're going to say, well, I thought cholesterol was bad. Why do you need to make cholesterol? Well, it's actually pretty important in terms of building different cells, different vitamins, different hormones in the body. And so your body does need a certain amount of cholesterol, and the liver provides that. So the other source of cholesterol then is from dietary sources. And this is something that, unfortunately, if you have a genetic predisposition to having bad cholesterol, you can't control all of it with just changing your diet, but definitely diet has a big contribution to what we can do in terms of taking ownership or taking control over this risk factor. So like I said, not all cholesterol is bad. There's actually, we're going to look at the different components of the lipid profile, but some cholesterol is actually good and necessary and actually preventative for heart disease. But if there is too much of that bad cholesterol, which what we talk about is LDL cholesterol, it can lead to an increased risk of atherosclerosis. And so let's talk about what atherosclerosis is. So it literally translates to hardening of the arteries. And what that means is that a normal, and this is obviously a cartoon, but a normal artery has like a nice smooth inside. And so there's no lumpy, bumpy stuff. There's no plaque. There's no, it's just a nice smooth inside. But when plaque actually starts, it starts because of elevated LDL as being one of the major contributors to this. And it starts off as a fatty streak. This is completely asymptomatic. It's something that nobody would ever know that they have unless somebody took a picture to find out. And then it just develops. So if risk factors, including LDL cholesterol, are unmanaged over time, it just develops and plaque progresses and then progresses and progresses until it becomes something that actually is causing enough of a stenosis, enough of a blockage in an artery that it can lead to symptoms, or it can lead to an abnormal stress test. The scary thing is that some of these plaques, and not all plaque is bad plaque, some plaque is actually stable plaque and it's just there, but the bad plaque is the one that's not stable, is the one that's not recognized, and risk factors are uncontrolled, and there's a high inflammatory risk going on for an individual patient, which is this bar here, the inflammatory markers. Well, that turns into an unstable plaque. And those are the ones that can lead to a heart attack or lead to unstable symptoms. So again, this is the inside of an artery that's nice and smooth on the inside. And this is what it looks like when plaque starts to develop within that wall. So you can see that the wall is pink. Here the wall is pink, but all of this is just fatty plaque. And so, like I mentioned, it's because the LDL cholesterol gets oxidized and then picked up by these cells in our bloodstream called macrophages. And it initiates this whole cascade that actually drives not only the development of the fatty streak and the development of plaque, but also the progression of atherosclerotic lesions. And once somebody has plaque in an artery, it's actually something that's systemic. So we think of this as a systemic disease, the same way that you think of diabetes as a systemic disease. It's something that can affect any vascular bed. So just because somebody has plaque in their heart doesn't mean that they don't also have plaque in the arteries leading to the brain, or in the arteries leading to the kidneys, or in the arteries leading to their legs. So this is a systemic illness once it's diagnosed. And we know consistently from several trials that the reduction in future vascular events is directly proportional to the absolute reduction in LDL cholesterol, regardless of the method of lowering that cholesterol. And part of it, and our mainstay of therapy, has been statin therapy, which I think most people have heard of before. But part of it is that leads to plaque stabilization over time. So let's take, I think people just like looking at normal or at angiogram films. I know I always did before I knew what I was looking at. So this is a normal angiogram. These are vessels that you can see inside the wall of the arteries. It's nice and smooth. You can see that it gets, it's thicker on top and it gets slowly more tapered, but it's not like thin and ratty at the bottom either. So these are normal coronary arteries. And this is what normal coronary arteries look like during the time of a cardiac catheterization. So it's the same patient, but normal arteries. This is a patient who also, happens to have a valve replacement, but you can see here that this is what happens when plaque progresses and it gets to a point where it's critically stenosed. And you can see that there's an obvious tightening here. And what happens in the cardiac cath lab is that that patient gets a stent and that restores blood flow through that artery. This is another picture of the same. So this is the same patient who had disease on the other side and the other vessels of his heart as well. And you can see here, same thing. Look at this. So once atherosclerosis starts, it's systemic. It affects not just one artery, but the entirety of the artery and any artery in the body. So you can see here, then this patient needed another stent. So luckily we do have invasive or interventional therapies that can help with dealing with plaque once it becomes significant. But the whole point, and this is, again, I just like this picture. So this is what happens when a plaque ruptures, what I was talking about with unstable plaque. This is a heart attack. So you can see here that this vessel clearly should keep going, but it doesn't, it just cuts off. And this is that same vessel once there's a stent in it and blood flow is restored. So the point of showing you all those pictures, other than showing you nice pictures, was that it's something that affects multiple different, you can have normal arteries or you have diseased arteries. But once you have diseased arteries, it can affect several different locations of the same artery or several different vascular beds. So the only way that we know if somebody is at risk is to check a lipid profile, to check a cholesterol profile. And the guidelines say basically that anybody who's in adulthood should have their lipid profile checked every 5 years. So after the age of 20, you should be checking it at least every 5 years. I would argue that needs to be more frequent. There are 4 major components, but the way that a doctor or the way that anybody should read a cholesterol profile is to look at what the baseline risk profile is for that patient. So you can see here, this is coming straight out of the guidelines from this year. If a patient already has vascular disease, if they already have clinical ASCVD, atherosclerotic cardiovascular disease, then it's for secondary prevention. Those patients, we want their numbers to be perfect. We want their numbers to be as low as possible, right? I mean, the bad numbers. And then if it's for the primary prevention patient population, well, you have to think about other risk factors. So what is their overall cholesterol? What is their diabetes profile? Because patients with diabetes are almost as sick as patients who already have heart disease, because we know it's such a major contributor. And so looking at all of these numbers, it's not just with one lens, you have to look at it in an individualized manner. So the total cholesterol is the first thing that's usually reported. The goal is to be less than 200. But remember that there is one component of the cholesterol profile that's actually a good cholesterol, which is the HDL cholesterol. So H stands for healthy. And so the goal is less than 200. But if you have a total cholesterol that's 180 and your HDL is 80, well, then I would argue that that's a very good total cholesterol, right? So sometimes it's really important to also look at the non-HDL cholesterol, because that'll give you an accurate number of the bad numbers, the bad components of the lipid profile. The one that we've been focusing on, the one I've been talking about, is the LDL cholesterol. So think of L as lousy, and this is the bad cholesterol. And the goal, because this is so clearly linked to future heart disease risk, the goal is based on a patient's baseline cardiovascular risk. So in the general population, if somebody has an LDL cholesterol that's greater than 190, they start therapy, even if they are, it doesn't matter how old they are. It doesn't matter what other risk factors they have. If their LDL cholesterol is greater than 190, you start statin therapy. And the reason for that is that oftentimes these patients do have a genetic link. There are genetic markers that are linked to high cholesterol, but it just doesn't make sense to test the entire world who has high cholesterol for genetic markers, because we know that the therapy would be the same. So that's in somebody who has a severely high LDL cholesterol. For anybody who has no risk factors, for a normal, young, healthy person, the LDL the goal is to be less than 130. In somebody who has one risk factor, I would argue that should be less than 100 and lower if you can. And in anybody who has heart disease already, or anybody who has diabetes already, or anybody who has other very high risk markers, several risk factors like hypertension and diabetes or anything like that, their LDL cholesterol should be less than 70. And I would say the lower, the better. So we have patients who have LDL cholesterols in the 20s, and it's okay. So the HDL cholesterol is the healthy one I was talking about. So H is healthy. The goal is to be the higher, the better. So the exact opposite. So greater than 60 is perfect, but greater than 40. Women do have a little bit higher HDL cholesterol due to hormonal influences. So we typically say for women, greater than 50 is what's expected, and greater than 60 is ideal. But unfortunately, we don't have a whole lot of medications that can treat low HDL. We have a lot of medications, and that's what Dr. Kim is going to talk to us about, to treat high LDL cholesterol. But the same is not said about raising the good cholesterol. And then triglycerides, so that's directly affected by the fat that you eat. It's just the fatty part of the cholesterol, and that the goal is less than 150. And if it's greater than 500, then that's severe and should be treated. So in patients who have heart disease already, I'm not talking about the prevention type of patient, although I would say that patients who have heart disease still need to be prevented from having more heart disease. But in the patients who already have stable ischemic heart disease, that's what that stands for. The guidelines all say that they should have a package of goal-directed medical therapy, including interventions and medications that have been shown to improve future cardiovascular outcomes. And that includes a healthy diet, which Dr. Karmally is going to talk to us about, weight loss to achieve an optimal BMI, regular physical activity. So the AHA tells us you should do 150 minutes of moderate intensity exercise every week. So that's 30 minutes on the weekdays, or you can do 150 minutes of vigorous activity if you're like a weekend warrior. Smoking cessation obviously is something that we should be counseling everyone on, and hopefully none of you are smokers if you're logging into a prevention talk. Baby aspirin for patients who already have heart disease, and that's a whole topic unto itself. Maybe we'll have a future session about talking about aspirin. Antihypertensive therapies to achieve a target blood pressure, and those goals have come down recently. So you know that again, lower the better. So a systolic blood pressure less than 120, a systolic blood pressure less than 80 is what's considered normal. And then sugar control, so glycemic control, if you're a diabetic or if you're a pre-diabetic. A third of the country is pre-diabetic. Most of them don't even know that they are. And so this is something that we definitely have medications that can improve long-term outcomes and that we should be focusing on more. And then again, for all of these patients, moderate to high intensity statin therapy. But looking at patients who have, this is a study looking at 3,000 plus patients who already have heart disease, who already have coronary disease. It turns out that lipid management is actually the worst treatment goal that was achieved. And only 18% of patients, when they presented with a known history of coronary disease, actually had target lipid levels. And like I said, there's good medications to treat this. So statin therapy has been around for a long time, Dr. Kim is going to talk more about this. This is just looking at a meta-analysis of 26 trials looking at statins over decades, included over 170,000 patients, and it shows time and time again that the risk of coronary events, any major revascularization procedure, any stroke, all vascular events are all reduced, cardiovascular death all reduced with the use of statin therapy. And yet, even amongst the highest risk patients, those who already have atherosclerotic disease, it turns out that even like almost half of them, 49.9%, so I would say half of them, are not on any statins whatsoever. And this risk of underutilization is higher in women, in patients who are younger, and in those who have vascular disease that doesn't necessarily affect the heart, but let's say they've had a prior stroke, or let's say they have peripheral artery disease. So at Columbia, we have an ongoing study, and this is just one of several that are similar, but we look at patients who are coming in for a cardiac catheterization, so elective percutaneous coronary intervention. And they are stable, they're coming in as outpatients, but their LDL is greater than 70. So we know that those patients with heart disease should have an LDL that's lower. And we look at basically intensifying their therapy at 2-month intervals, as opposed to what's commonly done in the community. And what our hypothesis is that this is something, lipid management is something that is not intensified as frequently as it should be to bring patients to a target LDL goal. And so we have an algorithm. We intensify therapy at 2-month intervals in a stepwise fashion in those patients who are randomized to intensive management. So we shall see, but I think this is something that all institutions should be studying, looking forward prospectively. And then let's just take a minute and talk about diabetic patients, right? Because we've done a lot of these seminars focusing on how diabetes is the biggest contributor to heart disease, and this is the epidemic of our lifetime due to the obesity epidemic. But let's talk specifically about how atherosclerosis is affected by being a diabetic. So plaque in diabetic patients is not the same as plaque in non-diabetics. And that's something that is driven by several different mechanisms. You obviously don't need to know any of the stuff that's on this flow chart. But being a diabetic just is a pro-inflammatory state. It also makes blood more prone to clotting and increases the risk of plaque rupture, so that unstable plaque I was talking about. It also negates the beneficial effects of HDL cholesterol, and actually it's been insinuated that the HDL cholesterol is lower in diabetic patients, though the mechanism, I believe, is not clear. And then diabetic patients actually have a higher small, dense LDL. So even with normal LDL levels, whatever LDL is there, it's actually more dangerous. And so particularly in this patient population, we really want to drive the LDL down as low as possible. This is an old slide. This is coming from 2017, and there's clearly been updated ones, but I didn't want to give you this whole flow chart looking at, statin therapy in every patient population. But essentially, if you look at it, if you are a diabetic patient who has any other risk factor or has heart disease, you should be on a moderate or high intensity statin. And that is the takeaway from that. So to sum up, I will say bad cholesterol, particularly the LDL cholesterol, can be a silent killer. Nobody will know if your LDL is elevated unless it's checked by a doctor. And that's part of, I'm going to plug in talking to your families, because a lot of it is genetic and it's something that can be picked up if you know a good family history. Anybody who had early coronary disease should have their LDL, if your parents, if a first degree relative had early coronary disease at a young age, they should have their LDL screened much younger. LDL lowering is directly correlated with a reduction in future atherosclerotic cardiovascular events. And despite several therapies that we have to lower LDL cholesterol, and I've just mentioned one, but Dr. Kim is going to go into that in more detail, these medications are definitely underutilized at the present time. And everyone's risk profile is different. And therefore, the target levels, particularly for LDL, but just for anything, for anybody's risk stratification, it's always targeted to the individual. And so diabetic patients, and so that's part of the reason why everyone needs to go and see their doctor on a regular basis, because particularly to talk about future cardiovascular risk. And then the last note is that diabetic patients are at a higher risk, and we've had several seminars, so please go to our website to see any further detail about that. But diabetic patients are definitely at a higher risk, and then they should be treated more aggressively. So with that, we're just going to shift gears. And like I said, Dr. Samuel Kim from Cornell is going to give us more of an overview of all of the lipid-lowering therapies that are available to us. So Dr. Kim is an assistant professor of medicine in the Division of Cardiology at Weill Cornell Medical College and New York-Presbyterian Hospital. He's a preventative cardiologist and a clinical lipid specialist within the preventative cardiology program. And so we're thrilled that he's been here, that he's joined us to be our expert in talking about lipid-lowering therapies.
Thank you for the invitation for this talk. For this talk, we'll focus kind of more on the practical aspects of some of the therapies and medications that are currently available for lowering cholesterol. The title of the talk is Lipid Lowering Therapies from the Tried and True to the Up and Coming. The major objectives of this talk is threefold. One is to understand the impact of lifelong exposure to LDL cholesterol on the risk of developing heart disease and other vascular diseases such as peripheral arterial disease and stroke. Number two, evaluate the current recommendations for who should be on cholesterol-lowering therapies. And then three is to discuss the currently available medications for lowering LDL therapy in this talk. So I know Dr. Jhalani in her first talk emphasized this point, but I think I wanted to just highlight that it's the prolonged exposure to high LDL cholesterol that is associated with your risk of developing heart disease or anything with plaque in the arteries of your vessels. So if you look at this graph here, we do know that over time, as you accumulate LDL cholesterol in your bloodstream and that builds up plaque, your risk of heart disease goes up over time. And it's the area under the curve. If the y-axis is your total LDL and the x-axis is your time, it's really that area under the curve that determines your risk of potential heart disease. If we look at the second slide, this is, I think, a nice representation of what can happen at different LDL levels. So if somebody has a genetic mutation, what we call familial hypercholesterolemia with high LDL at 200, they are going to be at much higher risk of developing heart disease earlier in their life due to the prolonged exposure. As opposed to somebody who has more of a typical LDL, like 125, their risk is going to be a little bit less, but their risk of heart disease is going to be much later in life, somewhere probably in their 60s, mid 60s, or closer to 70s. And for people that are able to get their LDL level down, whether that is through dietary changes or medication therapy, if you even get that LDL down modestly from 125 to 80, your cumulative exposure to that LDL cholesterol is much lower. So your chances of having your heart disease is much, much later in life. And this is important when we think about the dietary changes and the medications that we use for treating LDL cholesterol. This is another way to look at this, this is from the CTT meta-analysis, which was looking at all of the statin data that's currently available. And then for about every 39-point drop in your LDL cholesterol, that reduced your cardiovascular event risk in the long run about 22%. So both of those slides are to simply explain that, lower is better and that earlier start to prolonged reduction in LDL cholesterol is critically important for a heart healthy lifestyle. The second objective is to understand the LDL targets that Dr. Jhalani briefly mentioned as well too. So this is somewhat simplified, but the way that we approached it is that for primary prevention for those without known heart disease, we aim for an LDL really less than 100 milligrams per deciliter. And a lot of that depends also on your risk factors. I mean, certain risk factors like diabetes or chronic kidney disease, we would be a little bit more aggressive about treating therapy. And certainly patients who have LDL levels of 190, what we call familial hypercholesterolemia, we would be more aggressive about therapy. And then for secondary prevention, which are people with known plaque burden, such as coronary artery disease, peripheral arterial disease, or stroke, we do recommend an LDL goal of less than 70 milligrams per deciliter. The European documents advocate for less than 55, and the US guidelines are kind of moving in that direction as well too. But this is just a good frame of reference of what we are aiming for depending on the risk factors you have. So based on that, we'll do objective 3, which will be to talk about the 4 main medications that are currently available for lowering LDL cholesterol. They would consist of number 1, statin, number 2, ezetimibe, and number 3, bempedoic acid, and number 4, PCSK9 inhibitors. We'll start with the statins, which are the most commonly used cholesterol medications to lower your LDL cholesterol, the bad cholesterol. So these work in your liver and it blocks the cholesterol pathway in your liver. And as many of you guys are aware, there are multiple options for statin therapies at this point. The 2 most commonly used in practice, clinical practice, is rosuvastatin, which is Crestor, and atorvastatin, which is Lipitor. These are medications taken once a day orally. And I think it's important to highlight that even at the lowest dosage, you can still get close to about a 30% reduction in your LDL cholesterol. And at the highest dosage, you usually get about a 50% reduction in the LDL cholesterol. And I think this is important to remember because sometimes we read a lot about some of the side effects and the kind of the scary myths that comes along with statin therapy. And it's important to note that even at the lowest dosage, you get your most reduction and with the minimum amount of side effects. So sometimes that's a good starting point for thinking about medication if dietary changes has not worked to get to the LDL target that you would like to be. The most common side effects that patients endorse, if they do get it, are muscle aches, slight liver enzyme elevation, and some mild blood sugar increase. Of those, probably the most common side effect we see are the muscle aches. In clinical practice, about 10 to 15% of patients we see experience this, although in clinical trials, they have been closer to about 1 to 2%. Those are much common as you get higher dosages. But the good thing is, for the most part, these side effects are reversible upon cessation of the medications or reduction of the medication. So I think that's important to remember when we think about the medications. Number 2 is ezetimibe. This is another oral medication, and this works by blocking the cholesterol absorption in your small intestines. It has been around for quite a bit of time as well, along with the statin therapy. It's also 1 single dose. It's a 10 milligram tablet once a day. And for a lot of people, the side effect profile is less, so it can be used as an alternative or as an add-on therapy, the statin. When combined with the statin, there is a synergistic effect, meaning that it actually amplifies the LDL lowering effect, and you can actually get more reduction on that. We usually say an atorvastatin 10 milligram tablet combined with 10 milligram ezetimibe is roughly equivalent to the potency of atorvastatin 80 milligram, the high intensity statin. So this combination sometimes can be used as to relieve some side effect or as an add-on therapy to get additional LDL cholesterol lowering. The most common side effect that we experience in clinical practice are abdominal discomfort, some degree of liver enzymes for some people. Those are probably the most common side effect that we see. Small number of people still can get muscle-related side effects, but it's generally well tolerated, and roughly we see about a 20% reduction in your LDL cholesterol on average. But however, some patients do respond more than anticipated, what we call hyper responders. So it's always worth a try for patients who may not tolerate statin or as an add-on therapy for additional LDL lowering. Number 3 is bempedoic acid. This is the third oral agent that was just FDA approved about 2 years ago. And it can come in as a single tablet, 180 milligram tablet once a day, also taken orally. But it can also be taken as a combination pill with the ezetimibe that I just described. It does block the cholesterol pathway in your liver, similar to the statin, but in a slightly different mechanistic way. And the benefit of this is that it seems to have much, much lower risk of muscle side effect compared to the currently available statin therapy. The major side effect that we discuss are it can increase your uric acid. So people with recurrent gout, it is recommended to be mindful potentially for starting therapy. And then for people with significant tendon issues or tendon rupture, there is somewhat of a relative contraindication. By the pill itself, we usually get about a 20 to 25% reduction by itself. And then with the combination pill, we can get about close to about 40% reduction in the LDL. The generic name is bempedoic acid. In the brand name, you'll see it either at Nexletol as the medication by itself or Nexlizet, which is the combination pill that we often see. And this can be used as either an alternative or also as an add-on therapy to the statin therapy, which are commonly used. And then the fourth class of medications that we use are the PCSK9 inhibitors. And these comes in two flavors at this time. And so they are available as monoclonal antibody or an RNA-based therapy. The monoclonal antibody formulations are injectable medication that you administer at home. It's been available since about 2015. And there are two major brands, alirocumab, which is Praluent, and evolocumab, which is Repatha. And these are generally used as every 2-week injection, although once a month formulations are available. And we can usually get about a 50% reduction in the LDL cholesterol on average. These are single-use pens that you inject either in your thighs or your abdomen or in your shoulder pads for most people in terms of injection. And, it is not like insulin where you have to titrate the dosage. It's a single dose and there's a little clicker at the end, then you inject for once every 2 weeks. I would say most people tolerate this very well, although there have been some people can get some abdominal discomfort or fatigue or injection related side effect as the most common side effects. These are monoclonal antibody, meaning these are antibodies that actually block the PCSK9 protein. And the PCSK9 is a protein. It's kind of like the garbage recycling tag on the cholesterol receptors. So by blocking that, your cholesterol receptors can stay in the liver surface cells for longer, and you can clear the cholesterol from the bloodstream more effectively. And it was developed based on mutations found in family members who have low levels of this protein and subsequently had much, much lower levels of LDL cholesterol and lower risk of heart disease. The alternative version that was just FDA approved this past December of 2020 is inclisiran or Leqvio. This is actually an RNA-based therapy, and it is just starting to get used more and more. This is a medication that targets the RNA of the PCSK9. So it actually infiltrates your liver cells and blocks the PCSK9 and the RNA pathway. And because blocking that will prevent the liver cells from making the PCSK9 protein, and you get the same similar effect, but with sort of greater specificity. The medication has to be administered in a healthcare facility at this time, meaning that it's got to be administered either in your clinic office or a hospital setting or a local infusion center. It is almost like getting like a vaccination in the sense that it's an injection that we give, not an infusion. It is given, on average, it's going to be given once every 6 months for every 2 times a year. But the first year there is 3 injections, meaning that it's given at month 3, month 6, and month 12. And based on the studies, the efficacy seems roughly similar to the currently available monoclonal antibody therapies mentioned, and you can get similar reduction. The idea of the RNA-based therapy is that hopefully with the fewer injections that maybe there will be less side effects. And then 2 is that there would be greater compliance where, it may be easier to remember to take a couple shots a year as opposed to taking an injection or an oral pill every couple of weeks or every day. Similar side effect generally has been very, very well tolerated, other than the injection related side effects. And then we do monitor your liver enzymes for patients on it in case some risk of liver enzyme elevations. But generally, both of these have been very well tolerated, both in clinical trial and in clinical practice. So the main takeaways for that is to just give a brief introduction of the therapies that are involved, there are so many therapies that are being developed and in clinical trials with SOL2, but those are the major one that's currently in practice that we use. So the three takeaway points are: one, it's really the lifetime cumulative exposure to LDL cholesterol that determines your cardiovascular risk. So it's not just based on one number you get on one lipid panel, but it's what is that LDL over the course of your lifetime. So even a modest reduction, whether that's through dietary changes or medications, can go a long way in reducing your cardiovascular risk. So the earlier we can start and the more prolonged we can suppress that LDL cholesterol, we can delay the onset of heart disease, peripheral arterial disease, and stroke. Number two, as a general rule of thumb, we would like to aim for an LDL target of less than 100 for those without known heart disease, what we call primary prevention. And for secondary prevention, those with known heart disease, peripheral arterial disease, or stroke, we aim for an LDL target of less than 70. And it is important to mention that lifestyle and dietary changes still remain the frontline therapy for LDL reduction that Dr. Karmally will talk more about. But now we have several medications that are available and more coming down the pipeline to get to the goals that we need to ultimately reduce the risk of heart disease. Thank you very much.
Thank you so much, Dr. Kim. That was amazing. So hopefully this gives people, and again, you don't have to become, cholesterol specialists overnight. But the point is that if you know what medications are available, then you know what to ask your doctor about. And so that's really what we're trying to have be the takeaway from today's session. So with that, we're going to shift gears and transition perfectly into Dr. Wahida Karmally, who is actually a doctor of public health and health policy and management and works at Columbia University. She is a certified diabetes care and education specialist, and she is a diplomat of the Lipid Society, the National Lipid Society. And then on top of all of that, she is also the associate editor for the Journal of Clinical Lipidology. And so with that, we're going to transition into what can you do to manage some of this risk at home now that we've terrified you. And so I'm going to pass it over to Dr. Karmally.
Thank you so much, Dr. Jhalani, for the kind intervention. And what I'm going to say today is about dietary fats and cardiovascular disease. Cardiovascular disease is the leading global cause of death, and preventive treatment that reduces heart disease by even a small percentage can significantly reduce nationally as well as globally the number of people who develop heart disease and the healthcare costs. So I will be discussing dietary fats for heart health and review nutrition strategies and discuss eating patterns to lower risk for heart disease. We need to follow the science and not become afraid to any internet qualifications of products, because evidence-based dietetics practice is the use of systematically reviewed scientific evidence in making food and nutrition practice decisions. The foods and beverages we consume have a profound impact on our health because 6 in 10 adults are living with one or more diet-related chronic diseases. And this is because of poor quality dietary patterns as well as physical inactivity. The major risk factors for heart disease that includes hypertension, disorders of lipid metabolism, that's high LDL cholesterol, high triglycerides, diabetes, obesity. Lifestyle modifications is the primary intervention. And as Dr. Kim specified, it's the frontline therapy. So we need to follow a healthy dietary pattern at every life stage. The dietary patterns that have been studied are the Mediterranean style diet, as well as the DASH eating pattern, the DASH being the acronym for Dietary Approaches to Stop Hypertension. As you will see in these pictures, the foundation of these two diets are vegetables of different colors, as well as fruits, whole grains, lean protein like fish, chicken without skin, unsalted nuts, and the use of unsaturated oils. And in the Mediterranean diet is primarily the extra virgin olive oil. So we need to customize at the same time according to our eating habits, and so that we enjoy foods that reflect our personal preferences as well as cultural traditions. So healthy eating can promote health and reduce chronic disease. And you can see through the life cycle how important it is to lower adiposity, lower LDL cholesterol. And as we grow older, we have many more risk factors, which includes high blood pressure, more adiposity, as well as risk for other diseases such as cancers. And eating healthfully can have an effect in lowering the risk for all these diseases. We need to focus also on nutrient-dense foods and beverages. So these nutrient-dense foods provide vitamins, minerals, and other health-promoting components such as antioxidants, and have no or little added sugars, saturated fat, and sodium. So the core elements of a healthy eating pattern would be vegetables, all types, particularly dark green, red and orange, as well as legumes, the beans, the peas, the lentils, as well as some other starchy vegetables. Include fruits, the whole fruit, not fruit juices, whole grains like whole wheat, as well as brown rice, as well, and oats. And if you include dairy, it should be fat-free or very low fat, milk, yogurt, cheese. And if you prefer to have soy beverages, they should be fortified soy beverages with the vitamin D as well as calcium in them. And the protein food could include lean meats, chicken without skin, eggs, particularly egg whites that are pure protein, thus albumin, seafood, and legumes, as well as unsalted nuts and seeds and soy products. And the oils should be the vegetable oils, and not coconut oil, but vegetable oils like olive oil, canola oil, soybean oil, corn oil, as well as seafood and unsalted nuts. So you may have seen this commercial or advertisement which says they're happy because they eat lard. Lard is the fat from the pig, and it is high in saturated fat. It is less saturated fat than beef fat, which is 46% saturated fat, and lard is around 39% saturated fat, whereas chicken is around 33% saturated fat. And at the same time, you have to remember the absolute amount of fat in any cut of pork is much higher. I'm sure you've never seen a skinny pig. So we made a lot of progress with research, and we know that we need to lower saturated fat intake, minimize intake of trans fats, lower cholesterol intake, and instead use unsaturated fats such as oils and unsalted nuts, and eat foods that have the viscous fiber, the soluble fiber like oats, as well as viscous fibers found in vegetables such as Brussels sprouts, okra, or in fruits such as strawberries, apples. And weight loss is also important in order to achieve a lipid and lipoprotein profile that will lower the risk for heart disease. So let's examine some of these fats and oils that we consume or are in our pantries. If you look at this figure, the red bars indicate that oil is high in saturated fat, and the green is the unsaturated fat, which is the alpha-linolenic acid, and the blue is also unsaturated, the polyunsaturated fat that's high in linoleic acid, and the yellow bars are high in monounsaturated fats, which is the oleic acid that you would find in almonds, in olive oil, in pistachios. The purple bar is also an omega-3 fatty acids from marine foods like salmon. And there are, and if you look at coconut oil again, it is over 90%, it's almost 90% saturated fat, which makes it solid at room temperature. And it's, each time I think I look at a glass of pina colada, to me, that's like a heart attack in a glass. Butterfat is also about 64, 65% saturated fat. Palm oil is around 50%. Palm kernel oil that's used in a lot of products is similar to coconut oil. It's highly saturated. So we need to substitute the saturated fat with unsaturated fat. It could be the polyunsaturated fat like in soybean oil, corn oil, or it could be the monounsaturated fat that you find in many nuts as well as in olive oil. And it's also important to include the omega-3 fatty acids, the alpha-linolenic acid, as well as the linoleic acid. These are the essential fatty acids, and which means that the body doesn't make them, we have to consume them. So saturated fatty acids have been studied in very well controlled, randomized controlled clinical trials and have been shown to increase total cholesterol and the bad cholesterol, LDL cholesterol, increase coagulation, which means increase clots in the blood, increase inflammation, increase fat in the body, the adiposity, increase insulin resistance that can lead to type 2 diabetes. So overall, it has an increased risk for cardiovascular disease. So the recommendation is that we replace saturated fat with unsaturated fat so that you can reach a goal of less than 7% of energy from saturated fat calories. In fact, the American Heart Association recommends if you have a high LDL cholesterol, you should have less than 5% of calories from saturated fat, which means if you're on a 1500 calorie diet, you cannot have more than 8 grams of saturated fat in the diet. And if you're on a 2000 calorie diet, you cannot have more than 11 grams of saturated fat in the diet in order to be able to lower the LDL cholesterol. So the saturated fatty acids are different kinds. It's lauric acid, myristic acid, palmitic acid, stearic acid. And the monounsaturated fatty acid is the oleic acid. And the polyunsaturated fatty acids are the linoleic acid and the alpha-linolenic acid. And the marine source of the omega-3s are the eicosapentaenoic acid, the EPA, and the docosahexaenoic acid, the docosapentaenoic acid, which is the DHA. So we need more of the omega-3 fatty acids in our diet, as well as the omega-6, which is the linoleic acid, as well as the omega-9, which is the oleic acid, and keep away from the fatty acids that are saturated, the lauric, the myristic, palmitic. So here are the food sources of saturated fatty acids. So it's all meat, such as beef, pork, lamb. Lamb has like 64% saturated fat, poultry with skin, and as well as the dairy foods, the whole milk, full fat cheese, butter, cream, sour cream, yogurt, lard, ghee, which is clarified butter. So if you take a glass of skim milk and add 2 teaspoons of butter in it, that becomes whole milk. So you can imagine how much saturated fat you're consuming if you're having whole milk in place of skim milk. There are plant sources of saturated fat, the coconut oil, coconut milk, coconut meat, palm oil, and palm kernel oil. So coconut oil has been promoted in the internet, and most Americans, there was a survey done that 72% of the Americans thought coconut oil is a healthy oil. Coconut oil is high in the saturated fatty acid called lauric acid. Over 47% of the coconut oil is lauric acid. And coconut oil has been studied, has been shown to raise LDL cholesterol. So looking at all the studies that have been conducted with coconut oil, the reviews showed that it does not support the popular claims that coconut oil is the healthy oil to lower heart disease risk. So, a lot of people believe in the hype, and coconut oil is like the miracle of the century. It's even, claims have been made that helps to prevent dementia. What I tell people is, you will get heart disease before you get dementia. You probably will not get dementia because you're going to get heart disease before that. So monounsaturated fats are associated with improved lipid levels related to both the cardiovascular disease and the type 2 diabetes, which is when it's replaced for saturated fat. And even by replacing 5% of the calories coming from saturated fat with monounsaturated fat, will have will lower the risk for cardiovascular disease as well as diabetes in healthy adults, and also improve insulin responsiveness in insulin resistant patients as well as in patients with type 2 diabetes. And there is moderate evidence to show that when you increase monounsaturated fat rather than high carbohydrate intake, it'll be beneficial for patients who have diabetes. And high monounsaturated fat, when it replaces a high carbohydrate diet, it results in improved biomarkers of glucose tolerance as well as diabetes control. So here are the sources of monounsaturated fat, which is olive oil, canola oil, peanut oil, safflower oil, which is the high oleic acid. There can also be a safflower oil with high linoleic acid, but this is the one with a high oleic, which is a monounsaturated fat. And nuts, the almonds, cashews, the peanuts, the pecans, the macadamia. When we talk about nuts, we ask patients to have a handful, not a canful of nuts, because all these fats are also caloric. Every gram of fat has 9 calories. So we need to be also mindful of how much fat we are consuming and not to eat without any restriction. Avocado is also a very good source of monounsaturated fat. Again, we're talking about a fifth of a small avocado that gives you about 45 calories, and not to be eating the whole avocado because there's going to be a lot of calories. So polyunsaturated fat also has strong and consistent evidence that if you can improve your lipid levels by substituting polyunsaturated fat with the saturated fat or the trans fat. So polyunsaturated fat significantly decreases the risk for cardiovascular disease. In fact, there are many more studies with polyunsaturated fat compared to monounsaturated fat, it can have even a more significant effect on lowering LDL cholesterol. So here are the sources of polyunsaturated fats, which includes the omega-3 fatty acids from the marine sources, as well as the plant sources, and the omega-6 fatty acids from the different oils, such as the soybean, the corn, the sunflower, the safflower, which is high in linoleic acid, including chia seeds, and will give you, it's a nice way of increasing the consumption of alpha-linolenic acid, which is deficient in our diets. If you use flax seeds, make sure you grind the flax seeds and keep the powder in the refrigerator, date it, and use it within the month. When you have these polyunsaturated fats, they're also prone to oxidation, so they should not be exposed to sunlight, but keep them in your pantry that's closed, or keep it in a refrigerator to prevent oxidation. If you eat walnuts that are sitting out for long periods of time, they're going to taste rancid. And the rancidity is because the fats in these oils or nuts have been oxidized, and oxidized fats are not healthy. Here is a list of the omega-3 fatty acids in seafood. And if you eat herring or salmon, tuna, they're all very high in the EPA and DHA. When you're choosing fish, you have to be careful about mercury content in fishes. The USDA publishes lists of fishes that are high in mercury, like swordfish, king mackerel, albacore tuna, shark, tile patients, particularly advisable for pregnant women and young children to avoid eating these fish. You may have seen this Time magazine with a cover which says, now you can eat butter. Actually, butter is not back because it is high in saturated fat. It's over 64% saturated fat. There's a recent report that butter reserves in the country are low. I'm happy about it because we don't need to eat so much butter because it does contribute to increasing LDL cholesterol levels. So trans fat is also a bad fat, and it's made from partially hydrogenated oils, and it was used by manufacturers to increase the shelf life of a product. And also when you're reusing fat to make French fries, it helps to prevent rancidity. So, but trans fat also has a bad effect on LDL cholesterol. It raises LDL cholesterol, and it also has a bad effect on HDL cholesterol by lowering the HDL cholesterol. So the manufacturers are now trying to make spreads without the trans fat. But when you look at a product, you have to make sure you look at the ingredient label. If it says it has partially hydrogenated fat, it means that it has trans fat. But a manufacturer is allowed to claim that it's zero fat if each serving has less than half a gram of trans fat. But if one cookie has less than half a gram of trans fat, the label will say zero fat. But if you eat 4 cookies, then you're going to get substantial amount of trans fat. So you have to be very careful in looking at the ingredient label as well as the nutrition facts label. Now let's examine this nutrition facts label that does not have partially hydrogenated fat, but it has butter and it has a blend of natural vegetable oils, and it says palm fruit. This sounds very exotic when a product says it has the oil of a fruit. But when you examine the nutrition facts label, a tablespoon of this is 1 level tablespoon, has a total fat of 11 grams and has 5 grams of saturated fat. If you spread 1 tablespoon of this product, the spread on your toast, it's like putting a tablespoon of beef fat on your toast. So while we speak of fats, we also need to make sure we convey the message that dietary cholesterol restriction is also important in lowering LDL cholesterol. So eggs again have been promoted to be okay because the kinds of studies that have been done have not used the right replacement or comparators. If you look at the recommendations of for dietary cholesterol by several organizations, including international organizations, they recommend that we need to reduce cholesterol as much as possible, less than 200 milligrams a day, less than 300, like the WHO says. When you eat 1 large egg yolk, it has 180 milligrams of cholesterol. So if you have a high LDL cholesterol and the recommendation is to have less than 200 milligrams of cholesterol per day. You cannot have an egg yolk every day. You can have egg whites. You can even have 2-3 egg whites because it's pure protein. Because you cannot have an egg yolk every day because you will also be consuming some form of meat, chicken or fish, which will also contribute to the cholesterol intake for the day. So you have to be assess your dietary intake and then make the right choices in terms of cholesterol-containing foods. We have done several studies at Columbia looking at dietary cholesterol, feeding eggs to young healthy men as well as young healthy women, and we found that it does have an effect in raising LDL cholesterol. There have been several studies, and they have been examined in a systematic review, and they have shown that dietary cholesterol significantly increase both total cholesterol and LDL cholesterol. So the summary of the studies show that small reductions in LDL decrease cardiovascular events in patients who have diabetes. So we need to be very careful for patients who have diabetes that we make recommendations of lowering cholesterol intake as well as the saturated fat intake. So going back to the Mediterranean diet, it has also an effect on lowering inflammation, because inflammation is linked to many diseases, including cancer, heart disease, Alzheimer's as well. Looking at nutrition facts labels is very important. It'll tell you the amount of total fat, saturated fat. But look at this label. It tells you that the saturated fat is not very high in that one serving. It's 1 gram. But if you look at the sugar in it, the label on the left says it has total carbohydrates 37 grams, but it has only 1 gram of added sugar. Whereas the other food label, the nutrition facts label, says it also has 37 grams of fat, but it includes 10 grams of added sugars. So 10 grams of added sugars is like 2.5 teaspoons of sugar. So when you look at a can of soda, a regular can of Coke, it will say it has, the 12-ounce can will have 40 grams of added sugar, which is like putting 10 teaspoons of sugar in your glass of the soda. So, we have all these different recommendations. We can enjoy food. We need to enjoy food. Instead of having so much saturated fat or even a lot of fat in the diet, we can use spices and herbs to make it interesting. But we also make selections from these different foods that will actually enhance health and lower your risk for heart disease. So we have lots of resources available on the internet. You can go to dietaryguidelines.gov, and there's also nutritionevidence-library.gov to show the evidence behind all our statements. So, we talked about lowering LDL cholesterol. We need to focus on that. A lot of people are trying to focus on HDL cholesterol. HDL cholesterol is not very clearly linked with heart disease. It doesn't mean you have to have a very high HDL, because there could be some mutations in the HDL that can actually be detrimental. So we need to focus on LDL cholesterol and not look at LDL HDL ratios, because when you look at HDL and say, okay, saturated fat can also raise HDL, but is that good for you? All fats raise HDL. In fact, even cholesterol raises HDL. So it's really important to look at LDL cholesterol, because that is shown to be directly linked with heart disease. So with this, I thank you so much for listening to this presentation.
That is perfect. Thank you so much. I feel like I learned so much, Dr. Karmally, from this, the whole presentation. I feel like we focus a lot, especially on the medical side, we focus a lot on the medical therapies that we have that could do all of this stuff. But I'm like looking at those nutrition labels and actually cringing on what I probably give to my children. So I think with that, I have one final follow-up question, which is, what type of oil do you each cook with at home? Because that's also a debate in my house.
I can go first. It's always extra virgin olive oil. It doesn't make the food taste Italian. I cook a lot of Indian food, and I use
olive oil. Wow.
I use extra virgin olive oil for everything.
And Sam, how about you?
Same. So we tend to use more olive oil also too.
That's amazing. Okay. So I think there's so much that we've talked about. I think we've given a lot of information. This seminar will be broadcasted on our website. It'll be put out on social media. Please watch it, share it with your friends so that they can also have the knowledge. I mean, I'm telling you, I, as a cardiologist, learned a lot from these talks. So I think just spreading the information is half of the battle. The other half of the battle is then getting to the doctor and taking the medications and changing your diet and buying the right oils and reading nutrition labels. It's a lot. But clearly this is something that's going to affect overall heart risk. So I am so happy that you were both able to join us. Thank you so much. It's been amazing. And I hope to have you back on future programs.
Thank you.
Thank you for the invitation. Thanks for all the great talks.